And this segment that we are talking about, spreading the word around, it's a very important segment for us actually. It is special because it is really highlighting the seed that CBEC has, for that program, right? It is telling us about our alumni. It's not only showcasing our alumni, but it's actually demonstrating and showing that this alumni is actually walking the talk they have learned. Each one uniquely in their own space, wherever they are, whatever they're doing, they have stories to tell you that are motivating. I mean, I find them motivating, and I hope the audience will find them motivating at the same time, because each one is in a different specialty, and what they bring out and the story they tell is really highlighting the journeys they have gone through. I will not stand and take time over here because I want to introduce them, and I think it was really a challenge to say कि इतने alumni में who to really call, because each one is working in different areas and doing a lot of great work, and there is a method in the way we have selected the people. So I am first going to call upon Dr. Amjad. Dr. Amjad is an assistant professor and works at Gajju Khan Medical College in Sawabi. I mean, he is one of our main prize because he is one of the very few coming from KPK. He has an infectious diseases background, and I think he is the first fellow in KPK who did his second fellowship in infectious diseases. He has played a very important role during the times when he was also a student with us and COVID was going on. So kabhi meeting mein he would also have to say that he'd have these official meetings that he needed to attend, and his stories are remarkable. I'm not very sure on which rough terrains he is going to highlight today in 15 minutes, because I'm sure there will be people who may want to know how he's been able to get through this journey. But Dr. Amjad, I'm going to give you the floor, and please.
So I'm really grateful and honored to be speaking in front of all my teachers and colleagues. So just most of my presentation is they are pictorials, so they will be easy to understand things. This is a picture from my hostel that I just took day before yesterday. This is the weather, and we were informed that Karachi is too cold, so bring something. It's raining, and anyway. You know that what does this mean to be in this country, so you might have some limitations to talk. I'm just alluding to some of the basic. I'm probably the only physician in this whole conference talking. The rest are surgeons. So, but I will be touching upon the biomedical ethics for the undergrads and postgrad, just one or two slides. By now things are actually changing. When we were students, we just had a 2-hour session in our 6 years of undergrad education of biomedical ethics. and that was by one of our professor, Siraj Sahab, who is no more with us. And the rest, whole medical education was relying on modeling for ethics. There were no formal sessions. But by now things are actually changing in our modular system, at least in the module that we have in our province. The prime module now have proper sections which are related to the ethics and its related issues. We are now teaching our students what an IRB or what a hospital ethics committee looks like and how they are doing. These are the areas which we were never even informed in our fellowships. And this was the first interaction with the CBEC team. It was 2016 when I was called to attend a meeting. I'm basically posted at Sawabi, so it's district which is away from Peshawar. And I met the faculty of CBEC for the first time. This was about a provincial bioethics committee, an initiative that was initially started from the NBC by the lead from Dr. Muazzam. And here we started discussing, and I started realizing, because the public health section of the directorate was actually involved. Why I'm calling it a ghost committee? Because it was the only meeting of this committee since 2016. And now we have a meeting on 14th of this month, just on Tuesday, coming Tuesday, where we will be discussing to restart this committee and maybe nominate someone regularly to have this event. 2016 and 2020, so every passing day while working in periphery is a story worth telling. When you do not have a lot of resources, when you do not have a lot of awareness, and you start talking like this, priorities are actually very different. So you face them and you have to bear them and you have to tolerate them at times, and there are most of the time you have to fight for them. So the approach of the public to the healthcare is actually gradually changing. Like we discussed this morning, we are gradually walking away from our cultures. In our larger VVC, we are walking away. So the same is the public attitude toward the healthcare is actually changing, and it is rapidly changing. During the last 10 years, you can see how the people are selecting their hospital, their care, and how they are approaching, and what are the differences there. The equity thing is actually grossly challenged, and the business models are coming in. Everybody is interested in corporate modeling of the health system, which is actually challenging, and the decision making is most of the time based on the financial directions or impact rather than something very much patient-centered. The politicization of health in this country, this is a dilemma, that we use health as a political stunt. We use things like, for example, in dengue, if it is a fumigation, you will get a call from the MP and MNA that I need fumigation in my area, and photo shoots and show it to the people that I've done something for you, without realizing what they are doing, without realizing the impact that have on their health and their environment. So the same is, we will be discussing it in the COVID context, like how it was challenging in making decisions for the larger people groups. People were interested to have ICUs developed in areas who were not having experts to run them, just to show the people that I have 10 bedded ICU in my periphery and this is what I've done for you, but who will run them? That was not the task, because the thing was mostly relying on the pictorials and the videos that this has been done. The insurance companies, this is an area worth debate, how they are dealing with the health system and how things are challenged. I will be touching on it for a brief, The ever-rising influence of pharma industry, yes, each one of us in this room know how this is unfolding. The rising cost of care, the new advances, and the declining trend of professionalism in the healthcare. So here is a photo that actually I took in US, in San Diego, and it is showing the homeless people on the roadside. And see the drawings on the wall. That was that was near the Balboa Park. I was just going there, and on the ways I just noticed that what's happening. And then I had the experience of seeing these patients in hospitals. And today, for the last 3-4 days, when it is a huge fire in LA, I'm just recalling all those homeless people around in these bushes and on the ways, walkways. I mean, the news is not yet complete. They are telling that they don't know how many casualties they have. But this is the situation in a very much developed countries. The way insurance companies are dealing with the public health issues. I can just quote one example, that you may not be getting treatment for your HIV or hepatitis if your insurance card is not offering that cover, and you have to pay for it. And if you are all alone and have nothing to pay for, you will be channeled, and it's a very lengthy way, and people then actually do not go for that care, and they end up in these difficult to treat infections. And this is an everyday scenario that you may see in these clinics. So this was just before this COVID. After seeing all this and passing through all these administrative difficulties in the Department of Health, I decided that I should have a formal education in biomedical ethics, because this is an area where we need a lot, and we cannot find someone to discuss. I've seen CBEC in 2013 when I was on a rotation in infectious diseases at SIUT, but that was a very informal, just a view, and I was not aware that one day I will be coming to this institution. It was like many years ago. I applied for the MBE and ultimately ended up in a PGD program. I don't know who was the psychologist on the panel who decided that you will be better in PGD rather than MBE. I say okay. And then just before starting, when I received my congratulation letter, oh, you are selected, I just checked. I have more than 200 emails from CBEC during my PGD, and those who are joining, they will learn it soon, that every morning you get an email and a deadline, and then you have to respond. Otherwise, you get a call. Are you sure you have read the email? Or you are responding? Yes, I am doing. So the art of engaging students throughout the program is simply next level, and I will say this because I had my 2 fellowships, and I've never been through such an extensive training for anything. And these were my colleagues during my session from Kenya, some in MBA and some in PGD programs. So most of this is COVID related, the true test of public health ethics. अब हम पढ़ भी रहे थे साथ, and we were passing through actual examples. It was during my first module when I was in Karachi, 2020. ProMed pe this news was circulated that something is spreading rapidly. Most of the people took it very light, but as I was using that for many years, I was a bit concerned that this thing may be a problem, and it was. And it took us just 2 weeks, rather less than 2 weeks, to be a global issue. It was a global issue that rapid. So on my return back to Sawabi from that first module with a lot of assignments, Within a week time, I was called by the Department of Health to lead the COVID as a clinical team lead for the province. So every day I was added to a new committee. I have to be a part of every committee. So just a few examples. एयरपोर्ट्स, कहने को बड़ा आसान है एयरपोर्ट्स. लोग पाकिस्तान के अंदर, हाउ पीपल केम बैक फ्रॉम the countries where they were working during the COVID. Initial days I was made a member of a national aviation policy for COVID. So then we were given a figure that some 65,000 people of the laborer are waiting in the countries for traveling. We need to develop a standard document for them to be shifted to this country. And it was a challenge. At the end, I asked one of my colleague member how many meetings we had for this, knowing the airplane, knowing the dynamics, knowing the transmission infection, knowing those who are infected traveling in a plane, and knowing those who are not infected traveling in a plane. How can somebody travel in a plane? How will they be received in airports? So we had 113 meetings, every other day a meeting, every other day a new policy change, every other day emergency call that we have a meeting at 9:30 p.m. So this would be like a day in and day out meetings, and then we will be developing a document impacting a lot of people. It's not that easy. This was followed by trace track policy that anybody who is coming to this country will be tracked. They will be tracked for 14 days. And we learned the geofencing model in this, how geofencing can be used for the good and how geofencing can be used for the bad. People in hospitals received messages that you were in contact with a patient who had a COVID and be careful. Then we have to work it out that those who are in hospital should not get these messages because they are already in contact and they are worried and they are in problem. They are not even willing to work without things, and we are further horrifying them by telling them that you are in contact and you may get the infections. Supplies and rationalization. I hope the hand is not going up quickly. Trainings. So trainings on many areas. It was not just the clinical management. It was on dealing with many scenarios. I can tell that for that many days when the pandemic was at peak, we used to come to the office at 7 a.m. and we used to stay there till midnight and discuss every aspect, to go to the field hospital, to go to the different districts, to see the response, to go as patients. We just presented to them like I am a patient, not knowing, they were not knowing, and we were observing and we were documenting. PPE, another huge challenge, working without PPE and convincing people to work without PPE, and then the PPE in the market with no quality or with low specification, risking patients, denying a supply during the peak was very challenging. Like you cannot deny a mask, and somebody was willing to wear it even if it was not working. I have to tell them, I have to resist. I remember that one day when I refused 96,000 masks, my DG Health was sacked in the evening. Why you refused mask? And I have to write a huge letter that I cannot expose my healthcare workers to the infection with this poor quality mask. They will be believing that they have a good protection, but that is not. So prioritizing care, even CBEC has written on it. Everybody was pushing for a bed, for ICU, for oxygen. Oxygen supply was a big challenge. Even provinces were fighting in between that my supply is not enough for my province. I am not going to give it to you at peaks. So we were struggling at that, and then it was difficult to convince people. Lockdowns and religious gatherings, an area, the virtue ethics and all these cultural ethics and public health ethics were these individual priorities compared to gross bigger population. When we were asked to give a guidance on religious gatherings, It took us 16 hours by clock. 2 बजे दिन को हम शुरू हुए, and we ended up next day morning to make 20 lines for the whole country, for the president to present to the country that these are your standards, and they were discussed between different sects and different religious leaders. And I was like the technical person telling them, this is how, this is yes, this is right, this is left. And it was like then pushing people. There are still people who are resisting. So we need to have something which is acceptable to each and every one. Vaccine trials, शायद मेरी बात बहुत लंबी हो जाए, I will leave it. Infodemic, आगे शायद वैक्सीन का एक कमेंट आ जाए. Infodemic is a thing that is even now these days we have another infodemic. तो अब उसको बर्दाश्त करते हैं. I hope everybody is now sane enough to look for the right news. Dying patients and dead body managements. Patients without attendants. You know, I'm telling, we are gradually moving from we are actually grossly moving. There were days in the beginning of my career that every patient was accompanied by 4, 5, 6 family members. Now every day we see patients with no attendant. उनको खिलाना भी, उनको पिलाना भी, उनको संभालना भी, this is all becoming a responsibility. So we need a lot of that education of biomedical ethics to take it as a responsibility. We are moving toward an era where we will be having all those patients coming all alone. So dead body management during COVID, again infodemic was the issue. The first body who was buried in my province was in an ambulance में उसका जनाजा पढ़ाया गया, and he was dropped into that grave in ropes. And the chief secretary called me to his office. What's this? मैंने कहा, this is a problem with your district administration. Let's talk to them. And we had a conference with them and explained it to them that this is not the way to deal the dead. So, resisting experiments. Everyone has a new thought. Everyone was giving a new test. ये चीज़ मैंने इस्तेमाल कर दी, it's working very well, and use it. So it was resisting at the provincial level, a lot of herbs, a lot of things that were tried. So self-harm, self-medication, making it into a generalized thing. So we resisted a lot of them. The second last thing, they are very important. Clinical audits in public health emergencies. If you have a shortage of healthcare workers, if you have a shortage of every supply, and then you start doing clinical audits and find a lot of lacunas and gaps, and you start telling the treating physician, this is a gap, I'm not going to work. The nurse says, I'm not going to work. So it was very difficult to tell them that these are our findings. Every death in the initial 6 months was analyzed in my province. And we then have to talk to the doctor in a way so that they should not feel bad, and then they should improve otherwise it was very easy to say that I cannot do it. And this was a huge challenge that a lot of area actually, they were resistant, there was resistance to follow the standard guidelines, and convincing them and telling them and explaining it to them was very difficult. The last thing, I'm a government employee, so you bear it, you face it. So काम भी करें and then have it. What I want to tell is, I'm sure this is good to have audits. They should have financial audits. But the aspect that I'm telling is, when there is an event like this, you are projected on all the medias that this has been done, and everything, and then you have to go to that same building as mulzim. So when you go to an institution as an advisor, you are received, sir, this is the way, parking udhar kare, do it. Same institution, I'm an advisor as well. And same institution, when I go as a mulzim, तो मोबाइल जमा करके उधर इस रास्ते पे जाएं, and you do it, and then you are asked questions. The question that I just want to tell is, one of the question, 14 करोड़ रुपए का waste आपने जलाया, explain it to us how. Now, can you risk your employees with an infectious waste if it is not properly segregated? No. The issue, the challenge was because the people were not trained, the people were deficient, the supplies were not available. So we have to explain it to them that we were not risking our staff. This cost escalated because of the risk factor. We cannot do it. So I resisted it, and alhamdulillah, we got a clean sheet after good 3 years. So the hand is just raised. Last quick. Just these are the pictorials of what we discussed. Vaccine hesitancy, vaccine trials, a lot in this country. This was the thing that actually pushed me to start openly telling that we cannot do it. So probably this was the reason we stopped this activity in the country. Lockdown was not that easy. It has an impact on the financial, cultural, so many things. You have to push for it. Vaccination by force was at times done, and testing at force was done. I remember a day when I was tested myself 3 times. In same day, 24 hours, I was tested 3 times. One in Peshawar, one in Dubai, and one in Abu Dhabi, same one day. Because so when you are telling them that this may not be good enough, so these were like we were challenged with a lot, and this was all going parallel to my PGD. So yes, this is a challenge, and this is a challenge with this population, that we will be facing certain similar things if we are not having our drills regularly to prepare for events like this. So must respond assignments and these online sessions where you are supposed to sit in with the camera on. Camera bhi ban nahi karna ji. I remember one day when I was going for that vaccine trial to Abu Dhabi, and I have to present my presentation in the waiting area in the Dubai airport, because I got a link and I say, okay, I'm now ready to present, because that was a must respond. So blog writing and response deadlines on the projects. Miss Anika was kind enough that she was very polite in this is the way, and we did it, alhamdulillah. Presentations and facing the team behind the computer, emails for reminders, the ever-stretched diploma. Probably this will be written, I hope they will be writing it, that this was the lengthiest diploma in this country for anyone. I actually asked that if we can have 5 more months, we may be able to be eligible for that thing. So these are my colleagues during my training. So biomedical ethics for the undergrad students, this was my project, and this I just want to tell what we are doing in my province. Now there is no module, just like I mentioned that we don't have a proper module in undergrad medical education, in postgraduate diplomas from even CPSP. So we introduced and we did this, and this was done in University of Sawabi. These were the participants. And this was, I've written it in bioethics links as well about this, and the effort is actually reaching to its maturity with the higher education department. Now the syndicate and everybody approved this whole module for the pharmacy Form D students, and it will be a component of their education during Form D in the coming years. NBCR. Expedited reviews during the COVID, we learned something very new. Aaj 2, aaj 3. So my colleagues from NBC are here. We cannot explain it in detail, because they were thick documents, 100 pages, 80 pages, 120 pages. Skim through them and read them, and then identify them and feedback. So this is what was the practical implication and application of what we have learned through our PGD program, and so far it's going well. This was a recent presentation that I had in the European Society of Clinical Medicine and Infectious Diseases, the overcoming language barriers in research So this is the pluriversality. How a language is restricting or keeping a hold on the literature and everything. So this is an extensive discussion topic for the ethics, that how language is a barrier to the communication. This was a very recent activity in Allama Iqbal Open University on contemporary bioethics, challenges and opportunity, where me and Dr. Amir, you were like the scientific committee members, and then we were attending a session in it as well. Thank you.